Hello and welcome to the second workshop of a series on behavior change. My name is Catalina Uihei Gomez and I'm a postdoctoral research associate working with the Applied Research Collaboration Northwest Coast. As a member of the MIDAS cross-cutting theme that stands for Methodological Innovation, Development, Adaptation and Support, my role is to provide methodological support to health and social care professionals who have an interest in conducting applied research. I've created these workshops as part of this support. In the first session, I introduced you to some of the most influential behavior change theories and models that serve to guide the development of health interventions. The session provided a theoretical underpinning of behavior change, and while it's not a prerequisite for any of the other workshops, it might be useful for gaining a deeper understanding of why we behave the way we do. So by all means, do check it out if you're interested. For easy access, just click on the link below. In this session, we will discuss why change behavior and what are the factors that can potentially have an impact on behavior and behavior change. By the end of the session, you will be able to explain why it's important to change behaviors, and you'll be able to critically consider the determinants of behavior and behavior change. Historically, the top 10 leading causes of death primarily consisted of communicable diseases such as pneumonia and the flu, diphtheria, or diarrhea. With the advance of medicine and the development of vaccines, many of these conditions can be now easily controlled. If you consider the top 10 causes of death in the UK and Northern Ireland now, relatively recent figures show that the problem to a great extent is down to non-communicable diseases or NCDs. As we can see on this graph in blue, 9 out of 10 of the leading causes of death are the result of an NCD, such as dementia, heart disease, stroke, cancer, and pulmonary problems such as COPD or chronic obstructive pulmonary disease. This trend is also true at a global level and not only in the UK. Collectively, they account for more than 74% of global deaths, and as the world is making progress in the fight against many infectious diseases and as populations age, we expect that NCDs will become increasingly dominant as the primary cause of death. Research, however, is clear that through behavior change, these conditions are preventable. The 5 big killers in the UK are stroke, cancer, heart disease, liver disease, and lung disease. They account for more than 150,000 deaths a year among under 75s in England alone, and the Department of Health estimates that 30,000 of these are entirely avoidable. These conditions have continued to be the leading causes of premature death in the UK over the past 20 years. It's well known that health-related behaviors have a major impact on our health. Smoking, for example, has been associated with cancers and chronic obstructive pulmonary disease. Excessive alcohol use can lead to liver disease, but alcohol consumption has also been associated with some types of cancers. Hand washing can prevent catching viral infections, poor diet is a risk factor for obesity and metabolic syndrome, and inadequate sleep can affect our cardiovascular health. The lack of physical activity can result in diabetes and different types of cancers, as well as musculoskeletal disorders. Medication use and non-use will influence disease flare-ups, and unsafe sexual behavior can lead to sexually transmitted diseases, HIV, and unintended pregnancy. Prevention is important because it can reduce the human cost of ill health, which often hits the poorest in our society hardest, and it can also reduce pressure on our health and social services at the same time. So focusing on important lifestyle risk factors and changing health behaviors are key to prevent disease and illness. A large longitudinal study by Elwood and colleagues followed more than 2,000 Welsh men for 30 years. They found conclusive evidence that not smoking, having an acceptable BMI, high fruit and vegetable intake, regular physical activity, and low to moderate alcohol intake was associated with a 50 to 60% reduction in the likelihood of developing diabetes, vascular disease, dementia, and all-cause mortality. They also found that the more healthy behaviors, the better outcomes. Peter Elwood presented this data over a decade ago and hoped it would dramatically change people's lifestyles and in turn disease and death rates, but disappointingly it didn't. So what does this mean? It means that despite increasing knowledge of the relevance of lifestyle to health and to survival, people don't really follow healthy behaviors, showing that knowledge is insufficient for change. So what other factors influence behavior and behavior change? There's a myriad of factors that can affect behavior and behavior change, including psychological, social, cultural, and economic determinants. In this section, we review the determinants of behavior within the context of interventions and how we can take these into consideration in practice and, most importantly, in research. What would you say causes heart disease? To some, the clear answer would be blocked arteries. But then again, what leads to those arteries to become blocked in the first place? It may be the unhealthy food and drink people consume, inactivity or sedentary behavior, or all the stress that we experience most days. But then, what is it that makes people feel stressed, that shapes their opportunities to be active, and determines their food and drink choices? Health is not simply a matter of personal choice. The circumstances in which people are born, grow, live, work, and age do matter. These are the social determinants of health, the causes of the causes, the underlying causes of health problems. These determine whether individuals and societies flourish or not. Over the past 20 years, both science and policy have taken interest in the social determinants of health, which are non-medical factors that influence overall health and health inequalities. These factors are important to consider because, as Sir Michael Marmot put it, why treat people and send them back to the conditions that made them sick in the first place? Dahlgren and White had specified a wide variety of factors that can play a role in our health. These include individual characteristics such as age, sex, ethnicity, and genetics, as well as individual lifestyle factors and health behaviors. These are sometimes referred to as downstream causes of health. Upstream factors that can enable or constrain health include social and community networks and general socioeconomic, cultural, and environmental conditions, including agriculture and food production, education, work environment, living and working conditions, unemployment, water and sanitation, healthcare services, and housing. Through this approach, we can take a wider view on the factors that determine our health while shifting the focus from only individual attribution and responsibility to wider community and societal organization that underpin health and health behaviors. We can also take account of socioeconomic and health inequalities. Many people lack the opportunities to be healthy. We can address health inequalities by tailoring interventions to people's specific needs, including their cultural, social, and economic needs and other protected characteristics. So let's look at some other factors that may influence our behaviors and our ability to change behavior. The communication style that we use, the agent, who's the person who delivers the intervention, the setting the intervention takes place in, the intensity or dose of the intervention, in other words, the number of sessions delivered to clients or patients, the duration of the intervention, so how long the intervention and each session is, whether follow-up is carried out, the physical and social environments the intervention is delivered in, the comorbidities or other conditions present that can interact with the condition targeted by the intervention, and finally, life events, perhaps stressful or even traumatic in nature, that may be happening during or after the intervention. So what can we do to tackle this complexity? This huge variety of different factors that influence behavior makes the context of interventions rather complex. In order to deal with this complexity, as a practitioner, what's important is to use a person-centered approach when assessing people's needs and planning and developing an intervention for them, as well as to develop the skills necessary to become a competent behavior change practitioner. It's important to provide clear information to service users on the behavior change interventions and services available and help them access these services. We also have to meet service users' needs in relation to a disability or any equity-related protected characteristic such as age, gender reassignment, race, pregnancy, or disability. Recognizing opportunity to change, for example during recovery from cardiovascular disease or becoming a parent, and recognizing when an intervention may not be appropriate due to personal circumstances are also essential to a person-centered approach. Prior to intervention, it's key to assess health in relation to the behavior and the actions needed. For instance, we can only choose the appropriate level and type of physical activity once we have considered the person's physical health and any conditions present, such as when managing weight during pregnancy. At the same time, we also need to match the intensity of the intervention to the person's need for support to change behavior. A person-centered approach also involves discussing the impact of behavior change on health and well-being, and finally, planning a review to assess progress towards goals and tailoring intervention and support accordingly are of utmost importance. So what are the skills necessary to become a competent behavior change practitioner? Practitioners need to develop assessment skills to be able to assess people's behavior through validated tools and measures, but also to assess people's needs to help select appropriate evidence-based interventions. Practitioners also need to be able to communicate effectively, for example, by giving people health, well-being, and other information, by using reflective listening, and knowing how to show empathy. The ability to develop therapeutic relationships with service users and enhance a person's motivations to change by encouraging and enabling them to manage their own behavior are also key skills. Finally, practitioners should be able to deliver the relevant behavior change techniques and help prevent and manage relapse. In the previous section, we discussed how a person-centered approach and appropriate practitioner skills are beneficial in taking into account the psychological, social, cultural, and economic determinants of behavior and behavior change. But what does this complexity mean in research? It's also important to consider what can be done in research to understand why an intervention may or may not be effective. So in the next section, I will provide an overview about how we can manage the complexity of interventions when conducting research. Intervention fidelity is an important concept to visit here. It's the extent to which an intervention was delivered as conceived and planned. And this can have an important role in our conclusions around intervention effectiveness in terms of achieving the outcomes the intervention targeted. We've mentioned the issue of complexity in interventions. So how can we disentangle intervention effects from the influence of the context and the wider system in which the intervention was implemented? We have to seek information on contextual factors and on the characteristics of the interventions because these could explain to what extent the intervention or the outcomes are sustained. In other words, we have to look at the integrity of intervention. Intervention integrity has the potential to impact the presence or magnitude of the effect and can help assess applicability, an important issue in practice. So it's essential to collect information about the contents of the intervention, who delivered it, and the format and timing of delivery. Process evaluations can provide us with a useful source of factors that potentially influence the effectiveness of an intervention and allows for unambiguous interpretation of the obtained results. Let's now see some examples. In a recent systematic review around maternal alcohol use, we synthesized data obtained from process evaluation of trials to identify factors that may have impacted on the effectiveness of the interventions. As mentioned before, this is called evaluation of intervention integrity. In the review, we identified 5 categories reflecting factors that perhaps interfered with intervention outcome, leading to conflicting findings on the effectiveness of interventions to reduce maternal alcohol consumption. The level of alcohol risk and consumption varied among studies. Motivational approaches and brief interventions work best with heavy drinkers who do not necessarily satisfy criteria for dependence. Additionally, low levels of alcohol use or high rates of abstinence at baseline leave little room to demonstrate intervention effect. Intervention dosage can also affect intervention effectiveness. Some studies use single-session motivational interviewing or brief interventions, while others tested multiple sessions. Although single-session interventions can be effective in heavy drinkers, there's no clear evidence specific to pregnant women. Multiple sessions may be more effective, especially for lower drinking populations, due to the repetition of the message. In terms of readiness to change, low consumption level may be due to the strong motivating effect of pregnancy to change health-related behaviors and the fact that motivated women are actually more likely to participate in an intervention. Motivational interviewing may be most effective with people who are less motivated, more resistant to change, and who are not ready to set goals. Underreporting may also be an issue. It's well established that self-reported alcohol use can be misleading, especially in heavy drinking populations. In maternal groups, underreporting may be driven by social desirability bias, wanting to look good, or recall bias, they don't remember. Also mistrust within clinical settings and fear of consequences, for example, fear of losing custody of the child. Therefore, self-report measures may not be adequate, firstly to identify those needing interventions, but also to determine the effectiveness of interventions. And finally, contamination of intervention can also influence outcome. Many of the studies we included in the review found a reduction in drinking irrespective of condition. Women in the control groups may have reduced their drinking due to the assessment alone or due to the recognition of their pregnancy. Additionally, if intervention delivery and other study processes such as data collection and analysis involve the same professional provider, qualities and learned behaviors may cross over the two conditions. If you want to learn more about making use of process evaluation data from trials and about the results of this review in more detail, please click the link below that will take you to a short webinar on systematic reviews and the use of process evaluation data to determine intervention integrity. Other research have demonstrated that it makes a difference who delivers the intervention, what the characteristics of the population at hand are, and what communication style is used. A study by Williams et al. Explored the effectiveness of a brief intervention to promote walking. What they found was that while the intervention had been effective in some contexts, it had no effect in this study. The authors suggested that this lack of effect was probably due to a failure to maintain intervention fidelity, so the intervention wasn't delivered as planned, but also the unsuitability of the behavior change techniques included in the intervention for the particular population. In terms of implication to practice, it's then important to consider who delivers the intervention and whether they have the appropriate skills to do so. Research have shown a strong link between self-efficacy and physical activity. A study by French et al. Investigated which behavior change techniques are most effective at increasing older adult self-efficacy and physical activity behavior. In contrast to previous findings, the study revealed that many commonly used self-regulation intervention techniques that are effective for younger adults may not be effective for older people. This may be down to the cognitive deficits of the older brain interfering with self-regulation and planning. While motivational interviewing is an effective approach to change health-related behaviors, it has been shown that the way it's delivered might be just as important as what is delivered. Therefore, it's important to isolate the different components or techniques used in motivational interviewing in order to identify which ones are responsible for change. If you're interested in reading more about the communication style techniques taxonomy that classifies motivational interviewing techniques, click on the provided PDF link. As demonstrated through these research examples, intervention integrity is key in explaining why interventions may or may not be effective. So how can we interpret research findings unambiguously and draw conclusions that are useful for further research and practice? A number of behavior change related taxonomies and ontologies have been developed to help us do just that. Intervention content can be classified through the use of the Behavior Change Techniques taxonomy, a hierarchical classification of 93 active ingredients of an intervention responsible for change. These are also called General Behavior Change Techniques, or BCTs. A more up-to-date transformation of this taxonomy is the Behavior Change Techniques ontology. Both the taxonomy and ontology provide a common language to describe interventions by which they facilitate a level of rigor and specificity in reporting intervention content. Additionally, behavior-specific taxonomies are also available, such as taxonomies in relation to alcohol, smoking, or physical activity. Identifying how behavior change interventions are delivered, including by whom, in what setting, and how, is also key to understanding intervention effectiveness. However, such information is reported inconsistently in intervention evaluations, limiting communication and knowledge accumulation. Behavior change intervention ontologies provide guidance on consistent reporting. In summary, investigating and improving the effects of behavior change interventions require detailed and consistent specification of all aspects of interventions. If you would like to learn about ontologies and taxonomies in more detail, please tune in to the next episode of this workshop series. The leading causes of death primarily include non-communicable diseases such as stroke, heart disease, or cancers, which to a great extent are the result of unhealthy lifestyle. But research clearly demonstrates that through behavior change, these conditions can be prevented. However, we now know that knowledge doesn't seem to be enough to make changes. We have explored other factors that influence our behavior and our ability to make changes, such as intervention content, the different contextual elements, and the wider determinants of health. Finally, we discussed how we can manage the resulting complexity in practice through taking a person-centered approach to meet individual needs and in research through clear and transparent communication of behavior change interventions. Thank you for engaging with this presentation, and I hope it is something you will be able to make great use of in your practice. I would be really grateful to receive your feedback regarding the learning material by completing our quick 3-minute survey. Please use the blue QR code on the slide or the link below. If you're up for a challenge and fancy testing your knowledge, please visit our website using the red QR code or the link below and complete the quizzes linked to Workshop 2.